what about strengthening activities? The guidelines, the general guidelines recommend 2 or more days a week of muscle strengthening activities that work all major muscle groups. This includes the muscles of the proximal muscles, the thighs, hips, abdomen, back, shoulders, and arms. And this can be done using body weight, free weights, elastic band, hydrotherapy, whatever equipment for resistance, etc. So what is moderate intensity of strengthening activity? And again, in the technical parlance, we talk something about one resistance maximum. That is the weight or resistance that you can only lift one time. So you know it's the maximum. You cannot lift that again a second time. Then we talk about something called 10 resistance maximum. So that's something that you can only lift or push against 10 times. And what we usually tend to do is take about 50 to 60% of that and work with that in terms of resistance exercise. But I would suggest to you that you really start slow and slowly increase. And listen to your body and listen to the signals that it's sending you in terms of, are you overdoing it? Is it tiring you out? Are you able to sleep well after all that activity? Do you get up rested the next morning? Yes, when you start something new, you're bound to have a little amount of soreness, but it should not persist. It should not make you hurt too much. It should not fatigue you for too long. So then in 2011, the American College of Sports Medicine put out a position stand on quantity and quality of exercise for developing and maintaining cardiorespiratory, musculoskeletal, and neuromotor fitness in apparently healthy adults. I love that apparently. Because I mean, as you all know, we are all apparently currently healthy. They also said that these recommendations, though they were for apparently healthy adults, they can also be used to develop individualized plans for adults with chronic diseases and disabilities. And the one thing they added to the 2008 guidelines that were published was that in addition to aerobic strengthening and flexibility exercise, they also recommended neuromotor exercise for balance, agility, and coordination. And I think this is important because as the general population ages, we know that falls are a huge issue, that there are so many hip fractures, and it's not only a personal burden, it's a huge societal burden in terms of cost of care. And that's true with the population with disabilities and chronic diseases. I hear this all the time for patients with muscular dystrophy that I've followed for the last 10, 20 years, that, you know, they're getting weaker, their balance is getting worse, they're taking falls, and they're afraid of falls, and that they're cutting back their activities, and that causes more disuse atrophy and a greater impact on their psyche because they're not going out as much, not able to do things with friends. So I think it's important that assessment of balance and management of falls become an important part of the program. So what are the current recommendations for individuals with FSHD? There was a workshop in 2010. It was an international workshop, and they recommended that, you know, aerobic exercise, strengthening exercise, flexibility exercise, hydrotherapy or pool activities, and recreational activities are all important and need to be incorporated into whatever plan we decide for and recommend for patients. How many minutes do I have, Dan?
2 or 3 minutes.
Okay. And so where did this, what was the evidence underlying these recommendations? In 2005, Dr. Wissing's group had done smaller studies of aerobic training and said that aerobic training is safe and can improve fitness. and her colleagues did a review of all the evidence that was there for exercise and said there is level 2 evidence, meaning likely to be effective, for strengthening exercise in combination with aerobic exercise for patients with muscle disorders. And Cochrane review, which is a stricter review, which only includes randomized controlled trials, said moderate intensity strength training appears not to do harm, but there is insufficient evidence to conclude it offers benefit. As long as it does not do harm, that to me is important. And I think we have now started being more comfortable with saying, yes, do exercise, because at least we feel it will not do harm. And the benefit may depend again on what stage you're at, what you can do, etc., etc. So we've already talked a little about the aerobic exercise, the strengthening exercise. I think range of motion exercise or stretching exercises are important, and especially in people who spend a majority of their time in a wheelchair or have limited abilities. You know, our joints are like any other mechanical components of a car. They need to be oiled, they need to be moved, they need to be used. And if you have scapular weakness and you really can't do much with your shoulders, then it's quite likely that your functional activities that you're able to do or that you perform become less and less. So even though it's your shoulders that may be affected, to a certain extent, you are now doing less further down the line. So that causes disuse atrophy there. Also with the shoulders, if they are not getting the full range of motion, you know, that may be contributing some to the discomfort and the pain. So we want to make sure that we recommend and that people perform range of motion exercises, preferably on a daily basis. And that if you are able to do it actively, and there are gravity minimized positions that a physical therapist can demonstrate to you, and that we hope to demonstrate in the video clips, where even if you can't lift your arms up in a standing or sitting position against gravity, you might be able to do it in a lying down position. And how do you do it? So that's one thing. Or you might do an active assisted exercise so that you can do some of it on your own, but part of it you need help. Or if you can't even do that, we can train a family member or demonstrate to a family member or with a family member how it might safely be done passively. So that's important. Then there are, of course, you know, some people, as I heard someone talk about swimming in the earlier session, find that swimming is very helpful to them. And, you know, water has been used since millennia for exercises. There's the buoyancy factor, which, you know, helps people with weakness. People who can't walk on land may be able to walk in the water. Water can be used to provide assistance as well as resistance, and the temperature can have an impact. You know, I enjoy going into a nice warm pool, sauna, I would love it. So, but some of the disadvantages for some folks is the dressing and undressing. You know, maybe it's too much for what you gain from being in the pool, or accessibility issues. If you're not able to go down the steps and there's not a ramp into the pool, that might become an issue, or the distance or the cost. So even though we tend to recommend hydrotherapy and pool exercises for its benefits, we have to think about, you know, what are some of the disadvantages or barriers that may keep people from using it. And lastly, recreational activities. I think those are essential. To me, if something feels good, that's half of the psychological impact of exercise and activity. And to me, pick what you enjoy doing. Pick what you want to do with someone else. We know from the exercise and activity literature is that when people do things with someone else, they tend to do it more often than when left to themselves to do it. So pick things that you can do with someone else, make it a social time as well as a physical activity time. And there are so many options. People ask me about yoga, people ask me about many, many different things. And the key is to work with someone who knows FSH, who's, if they don't know FSH, is willing to learn about FSH and work with you. Two things, and I'm going to wrap up. There's been a neuromuscular electrical stim has been studied for decades in individuals, not only with muscular dystrophy, but other chronic conditions that cause atrophy and weakness. And the goal of using neuromuscular electric stim is really to prevent disuse, atrophy, and provide a passive form of strengthening for the very weak muscles that we might not be able to strengthen with active exercise. And actually, it's Dr. Sacconi's group that published the study in 2010. They did an open pilot trial, 9 individuals with FSH. They stimulated these 3 muscles 5 days a week for 5 months. And they concluded that electrical stim appears to be safe, feasible, and well tolerated, but that it requires further study. We need to know, do you have to do it 5 times a week? If you continued past 6 months, is it still beneficial? And they also felt that multi-site studies with more participants need to be involved. I'm going to go past this. Pain is a huge issue. Low back pain, scapular pain, some of it due to the abdominal weakness. We have found that for some folks, some kind of an abdominal support is helpful. Fatigue, I'm not going to talk about. Dr. Engelin has shared their experience. But again, from the same group, falls in FSHD. What is the epidemiology and pathophysiology of falls in FSH? And we know weakness is an important risk factor. The elderly fall, people with chronic disorders and disabilities, there's a higher percentage of fall. But what is the relationship between weakness and falls in FSH had not been documented. And so the folks here did a study of prevalence, circumstance, and consequence of falls. They used a questionnaire and a prospective 3-month follow-up. It included 73 patients with FSH, 49 matched healthy controls. So everyone answered the questionnaire, and then they assessed strength and balance in a subgroup of 28 patients. And what they found was 30% of their patients reported falling at least once a month. Of these 30%, 70% reported injuries. The falls occurred at home. Folks usually fell in a forward direction, and the fallers were also unstable on stairs, on rising from a chair, and while standing with eyes closed, and that the frequent fallers had great weakness. And I bring this up because it's part of the recommendations for neuromotor training, balance, falls prevention, etc., and we know that this is something that needs to be addressed. So very briefly, coming back to the need for individualized recommendations, we need to take into account the age and hence the activities that might be of interest to the person. If it's a child or a teenager or a young adult or an elderly, their interests would be different and their clinical profile would be different and their personal profile would be different. And we need to take into account all these factors when we work with you to develop what is best for you. And in terms of implementation, you need a good evaluation, you need proper recommendations, you need good monitoring and adjustments as necessary. And to me, the biggest factor is the self-monitoring. This is a lifelong condition. I do not expect you, the healthcare environment cannot support the cost of everyone seeing a physical therapist 3 times a week. That is not necessary. There might be acute times, a fall, something surgical correction of the scapula. Those are incidents where you would need acute follow-up more frequently. But other than that, we are talking about working with a physical therapist as a guide, trainer, if you will, and monitoring every 3 months, 6 months, 12 months, as the need be, but you are going to be the person that manages your health, activity, and exercise needs, okay? But I think the important thing is teamwork and partnership, and I hope that's what we do.